Good morning, everybody. My name is Andrius Z. I'm a hematologist in Vilnius University Hospital Santaros Klinikos, Lithuania. And today I would like to present a combined regimen of Venetoclax, low-dose cytarabine, and Actinomycin D for relapsed to refractory AML patients who relapse very early after allogeneic stem cell transplant. The data has been already presented at EHA 2020. And today I've prepared a few slides just to present the data and highlight some important features of it. So usually half of the allo-transplanted AML patients relapse and face a very dismal prognosis with a 2-year overall survival of usually less than 20%. The most standard therapies we can offer those patients are intensive chemo, donor lymphocyte infusions or second allogeneic stem cell transplant, hypomethylating agents, low-dose chemotherapy, recently targeted therapy, IDH1, IDH2 inhibitors, FLT3 inhibitors, BCL2 inhibitors, especially Venetoclax, and best supportive care. So Venetoclax with either low-dose cytarabine or hypomethylators results in from 0 to 51% of complete remission or complete remission with incomplete blood recovery rates in patients who relapse after allo-HSCT. And the median overall survival is usually not impressive, with 3 to 6 months in most reports. Why patients fail Venetoclax-based therapies? MCL1 is an anti-apoptotic protein, which is considered an important mechanism of resistance to BCL2 inhibitors. And there's data that Actinomycin D, cytostatic drug, has MCL1 inhibiting properties, which are expressed both in cell lines, and the activity of Actinomycin D was also shown in relapsed refractory AML patients harboring NPM1 mutations. So based on this data, we combined Venetoclax with low-dose cytarabine and added the third drug, which is Actinomycin D, and we treated our relapsed refractory AML patients who relapsed after allogeneic stem cell transplant and had very limited treatment options. We collected clinical data in the past 2 years. The treatment was approved on per case cases on compassionate grounds by our institutional ethics committee, and the data collection was approved by our ethics committee as well. The active regimen consists of 3 drugs, like I've mentioned. Usually we give 1 or 2 cycles of induction, which consists of Venetoclax at a dose of 600 milligrams per day with no dose reductions, 10 days cytarabine, and 2 or 3 doses of Actinomycin D. The responders to this induction proceed to maintenance treatment, which is the same Venetoclax at a 600 milligram per day dose, with low-dose cytarabine, 10 doses, and we omit Actinomycin D just to avoid additional hematological toxicity. If the patients reach MRD negativity, we usually reduce the number of cytarabine doses from 10 to 5, just to avoid additional hematological toxicity. And if there's no active GVHD, patients receive regular DLIs. In a few cases, we've offered our patients a second allo transplant. Basically, it was the case when a morphological leukemia-free state was diagnosed after the treatment. For efficacy analysis, we evaluated the overall response rate, which consisted of complete remission with incomplete platelet recovery, or morphological leukemia-free state. And of course, the MRD negativity rates. We use descriptive statistics for baseline characteristics, safety efficacy analysis, and Kaplan-Meier for survival analysis. As you can see, we've enrolled 14 patients. The median age was 61 years old. The patients were in a relatively good condition with a median ECOG of 1. Slightly more often, de novo AML was diagnosed rather than the secondary AMLs. One patient had extramedullary disease involving CNS and soft tissues. And the majority of patients were stratified to the adverse ELN 2017 cytogenetic risk group. The patients were heavily pretreated with a median of 2 treatment lines consisting of intensive chemo. All of them, of course, were after allotransplants. 2 patients were actually were with prior venetoclax exposure. Reduced intensity conditioning was used in majority of patients, and the relapses were very early. Practically all patients relapsing during the first year after the transplant. So it's a big challenge to treat these patients. And what are the results? Well, we actually see that 8 patients achieved a complete remission, 2 patients were in a complete remission with incomplete platelet recovery, and 1 patient achieved morphological leukemia-free state, thus resulting in an overall response rate of 79% and a 71% CRP rate. Importantly, we see that majority of patients who are in CR, they achieve MRD negativity, whether by flow or by real-time PCR. Responses were achieved in patients with complex karyotypes, and even in the one who relapsed the earliest, within 3 months after allo-HSCT. NPM1 and IDH1/2 patients, not surprisingly, were doing very well, but we had less encouraging results with FLT3, KMT2A, and RUNX1 patients. So usually the best response was achieved after 1 cycle of active induction. The toxicity was manageable. The majority of patients suffered from infectious complications, but we've managed to treat those complications quite effectively. And the only day 60 mortality we witnessed was related to AML progression. Times to hematological recovery after active induction were adequate. We had 11 responders, which 8 of them proceeded to maintenance therapy. 2 patients were allotransplanted for the 2nd time, and 1 patient did not receive further maintenance treatment because she relapsed after cycle 2 of active induction. So the maintenance treatment was given in a median of 5.5 months, 5 courses, median of 5 courses of venetoclax and low-dose ara-C. The majority of patients received concomitant DLIs. And what's very important, we only witnessed 1 case of DLIs induced in GVHD. Maintenance was stopped in 4 out of 8 patients. 2 had relapsed, while the other 2 had other problems why the maintenance was stopped. The maintenance treatment was actually tolerated pretty well with only a few grade 3 events. So all in all, the high remission rates and possibly the maintenance treatment resulted in a quite prolonged overall survival of 14 months. The remissions lasted for a median of 9 months, and the event-free survival was 8 months, as you can see. And if you take a look at the swimmer's plot, it is obvious that patients who are in MRD negative complete remissions, they're doing very well. And in fact, they're long-term survivors. And the only patient who relapsed after achieving MRD negative CR was the young patient who had an aggressive extramedullary AML. So to sum up, venetoclax-based active with low-dose cytarabine and actinomycin D produces high remission rates in poor risk post-allo-HSCT relapsed and refractory AML patients. The toxicity is acceptable. The maintenance treatment with venetoclax and low-dose ara-C plus donor lymphocyte infusions may prolong the duration of response. And of course, we need prospective studies to verify these preliminary results. So in the end, I would like to thank all of my colleagues from Vilnius University Hospital, Santaros, Klinikos, and especially Professor Laimonas Griškevičius for his advice and guidance during this research.